Okay. Bismillahirrahmanirrahim. To begin with the greatest name of Almighty Allah, the most merciful and the most gracious, whose bounties are unbounded, whose benevolence is everlasting, whose blessings are uncountable, whose mercy is unlimited, whose love is our life, and whose worship is our faith. Ladies and gentlemen, distinguished guests, and esteemed speakers, Assalamu alaikum. I am your host, Ramsha Abid.
And I am Arshi Rahman. We are currently serving as resident pharmacist under ASHP International Pharmacy Program residency at Shaukat Khanum Memorial Hospital, Peshawar. We are delighted to be a host for today's oncology pharmacy sessions in 22nd Annual Symposium at Shaukat Khanum Memorial Hospital, Peshawar. Today, we gather to explore the exciting and ever-evolving world of oncology pharmacy. And it is an honor to guide you through this enlightening journey.
Oncology pharmacy plays a significant role in the treatment and care of cancer patients. Pharmacists in this field are essential members of healthcare team, ensuring safe and effective use of medication while providing invaluable support and knowledge to patients, their caregivers, and healthcare professionals. Today, we will dive into today's theme, that is forecasting oncology pharmacy, which includes artificial intelligence, telemedicine, and system innovation as we explore the future of oncology pharmacy practice.
Pharmacists contribute greatly to the world of oncology pharmacy, bringing their expertise in medication management to improve the patient outcome. Pharmacy professionals plays a vital role in selection, dosing, and administration of medication, considering their complex drug interactions and side effect profiles, which are often associated with the cancer treatments. They also provide crucial education to the patients, ensuring that they understand their medication and help them resolve any medication-related problem that may arise.
Just to give you all an outline of today's program, this session is scheduled for a total time duration of 90 minutes that will be concluded by a segment question and answers. So if you have any questions, you are more than welcome at the end of the session to ask your questions. Ladies and gentlemen, now it is time to introduce our chairpersons and to invite them up on the stage. I feel absolutely privileged to have among us our first chairperson, Dr. Mohammed Ismail Tajik, who is an associate professor at University of Peshawar, and he is from Department of Pharmacy. Dr. Mohammed Ismail Tajik has an impressive academic and professional background. He serves as an HAC approved PhD supervisor and coordinates all clinical pharmacy clerkship programs. He has produced 4 PhDs so far and 13 MPhil graduates. A huge round of applause for Dr. Mohammed Ismail Tajik. Sir, if you could please come on the stage and take the chair.
Allow me to introduce yet another impending personality, none other than Dr. Muhammad Tahir Aziz, who is the second chairperson for today's session. Dr. Muhammad Tahir Aziz is currently working as Chief Operating Officer at Shaukat Khanum Memorial Hospital, Lahore. He has done his B.Pharm and MPhil from University of Punjab and did his MBA from Lahore University of Management Sciences. He completed his PhD from Quaid-e-Azam University and has been serving at Shaukat Khanum Memorial Hospital for nearly 30 years, profoundly contributing to the prosperity of Shaukat Khanum Memorial Hospital.
Please welcome on stage Dr. Tahir. Now let me introduce to you another illustrious personality and a third chair, who is also the pride of our department, Mr. Umar Akhlaq Bhutta, who is the Associate Director of Pharmacy at SKM Lahore. He has served the SKM Trust for nearly 20 years and continues to be an integral part of SKM Trust. Unfortunately, he couldn't make due to some emergency, but he sent his regrets and good luck to our speakers.
The only thing standing between you and outrageous success is the continuous progress. Having said that, let me please welcome our first guest speaker, Dr. Fakhruddin. He is serving as head of the Nanomedicine Research Group at Quaid-e-Azam University and has published around 81 research papers with 5 international patents and 12 chapters in the books. Dr. Fakhr has received numerous awards, which include the Young Innovator Award from Korean Society of Medical Oncology in 2020 and Best HEC Researcher Award in 2019. Please join me in welcoming Dr. Fakhruddin on the stage to present on the topic Cancer Nanomedicines, Advancement, Opportunities and Challenges. Welcome, sir.
Next. Thank you very much for a very nice introduction. I am very much thankful to the Oncology Pharmacy Shaukat Khanum Memorial Cancer Hospital for inviting me here. Today, I will speak about the cancer nanomedicine, the advancement, opportunities, and challenges. This is about the global cancer burden, which is rising with the passage of time, as you can see. In 2000, 10.1 million cases reported per year, and it is expected to be 27 million cases per year, which is actually a very enormous and global cancer burden. It can be seen that majority of the cancer patients, they are from Asia, followed by the Europe, the America, and Africa and Oceania. Drug delivery is basically referred to a number of approaches and formulation technologies which together develop a pharmaceutical compound for the safely to reach the site of action and to achieve the desired therapeutic effect. We can say or ask, what is the desired therapeutic effect? Desired therapeutic effect of any formulation is that drug reaches the site of action at a particular concentration. And not only this, but when it reaches the particular concentration at any particular site, it retains over there for sufficiently long period of time to alter the disease process. So there are some hurdles to achieve these desired therapeutic effect, and there are many problems associated with the active pharmaceutical agents. Some of them include the poor bioavailability of drug. Some other include the degradation, the tissue toxicity, rapid clearance from the body, interaction with other cells, and incapability to penetrate into the deeper layer of the tumor environment. Nanomedicine could be a resolution or could be a source to minimize all those problems associated with drug delivery. These in the form of various nanocarriers, including the liposome, polymeric nanoparticle, a lot of other nanoparticles, molecules different by using external stimulation as well as internal stimulation. They can achieve the desired therapeutic effect. They result in prolonged circulation time. They have less accumulation, and they have site-specific delivery, improve the therapeutic index of the drug, and release the drug in sustained way so that desired therapeutic effect could be obtained. These are some of the marketed formulation nanomedicine product, including the Doxil, which was approved in 1995. It contains the doxorubicin, which is used, a very important antineoplastic agent. The deposit, Markibo, Abraxane, and recently Liposo is, containing the paclitaxel is one of the antineoplastic agent. It has recently been reported with excellent therapeutic efficacy index. We reported this article in Nanoscale Research Letter in 2017, and we reported that there are various nano containing agents, including the nano devices and nanomaterials, which could in the form of NAMs and MEMS and various nanostructured, whether they are polymeric in nature and non-polymeric in nature. They results in targeting, not only targeting the tumors, but at the same time, they could also be used as finding the tumor site when they are introduced into the body. This is the structure of very commonly used liposome. And you can see that this liposome has the ability to incorporate various Menno's moieties. They could be incorporated with various anti-cancer agents. They are lipid-based nanoparticle system. They are gadolinium-based imaging agents. They could also be loaded into the liposome, and folic acid molecule. They could also be loaded for the targeting as well as the imaging purposes. So these liposome, they has recently revolutionized the entire, you can say, nanomedicine field, specifically for the tumor targeting. How it happens, these are the lipid-based nanomaterial, including the solid lipid nanoparticles, and they are still liposome, conventional liposome, lipoprotein. And one of these technologies, they are actually adapted to make them help reach the drug at the site of action and approve the desired therapeutic effect. This could be either through photothermal surming, could also be in the form of radiotherapy, the gene therapy, chemotherapy, and you can say immuno and protein delivery, that they could also be used. And these are the targeting legends which could be used, as I discussed earlier, folic acid as well as Menno's receptors. They are used for the targeting agents. They could also be used for imaging as well as radio contrast agents for the targeting delivery. How these nanomedicine, they reach the targeted site is actually very important thing to have debate on. One of the most important strategy which is used by these nanomedicine is the EPR effect, which means that they use enhanced permeability retention. So you can see that the normal endothelial cell in they have very intact cells within them. There are no gaps between these cells. However, in the disease environment, or specifically in the solid tumors, what happens that because of the hypoxic nature, because of you see the revolution which happen within the tumor cells, there a certain gap is developed. So the nanomedicine, because of their smaller particle size, they can pass those areas and reach the tumor site. They can localize over there, and the tumor is actually, the drug is released. This is one of the mechanism. The next mechanism is the active targeting, in which we actually add certain moieties on them. We target certain environment, that could be the pH, that could be the biomarkers which are released in the form of tumor environment. So the active targeting, that could also be achieved, and we actually reported these in various international journals. Another very famous method by which, or you can say concept by which, these nanomedicine, they could reach their site of action is by this kaolin and clathrin you see pathways. In this particular case, the nanomedicine, they are basically mediated via the endocytosis by targeting these specific kaolin as well as the clathrin presence of you can see markers, and the drug is become part of it, and when reach their entire microenvironment of the tumor, they disband because of certain reasons, and because of the certain technologies that we adopt to prepare those nanoparticles. And the nanoparticle loaded drug, it become disband and result in altering the process. This is one of my very interest area, in which we prepare thermosensitive liposomal theranostic agent, which could not only be used for the imaging purposes, but at the same time, they help the drug reach the drug at the targeted site, and you see release the medication over there. So these are nanoparticles. They are dipalmityl phosphatidylcholine loaded nanoparticles. They are prepared anti-cancer agent and imaging agent. They could be loaded into this particular system, and when they are introduced into the body, just because of the EPR effect, or because of the targeted effect, they reach the tumor site or the area. And then we apply certain heating resources, or sometime we apply the ultrasound waves, and because of these, they reach you see the tumor environment. They disband over there because of certain reasons, because of the pH change, because of a lot of other changes in the system, and they actually results in the formation of replication of bubble because of the carbon dioxide release, and the DNA of those particular tumor cells, they become disinfective. This is some of the work that we have performed here in my lab and when I was abroad. So you can see that conventional gel or drug delivery system, they have a lot of problems, particularly when targeting the colon cancer. So you can see they have foreign body sensation, they have patient feels severe discomfort, and actually they have limited use in that. So our lab developed thermosensitive gelling system in which the foreign body sensation was addressed. They have active targeting, but they showed some burst release effect, which is of course not needed in some cases. So we developed smart drug delivery system, which are the dual responsive thermosensitive drug delivery system, which have actually dual release behavior. They should reduce toxic effect, minimize toxicity, and improved anti-tumor efficacy. We published this in 2015, and we have a Korean patent for that. We then reported a European patent to have this same phenomena for the treatment of colorectal cancer. So you can see that these formulations, they are basically at room temperature, they remain in the liquid form. However, when they come in contact with the body tissue, because of the rise in the temperature, they become gel system, and then they sustain release the drug, and you can say do the desired therapeutic effect. We also make a US patent with the same formulation when they were intramuscularly delivered for the treatment of ovarian cancer, and you can see the results were very significantly different. We check the pharmacokinetic and bioavailability of those formulation after the intramuscular administration in rats. You can see that after intramuscular administration of solution, one of the biggest problem associated with anti-tumor drug is that they have very low time inside the body. So when they are administered into the body, they just clear from the body within 4 hours. So that is a major breakthrough, that you can retain or your formulation for even 96 hours of the stay, and which results actually in excellent area under the curve Cmax, as well as the Tmax was significantly enhanced. So this result was very successful. We checked the anti-tumor efficacy of these formulation after the repeated administration in rats, and you can see that the formulation DRTG shows significantly reduced tumor volume over extended period of study of 20 days, and the body weight change was not significantly different. The body weight change is one of the indicator of toxicity of any formulation when they are taken. So as compared to the rest of the formulation, the product has low no toxicity evaluation. Morphology evaluation showed that as compared to the hydrogel, which was just a gel containing the anti-tumor agent, which was irinotecan HCl, it was safe as compared to the hydrogel, and it didn't cause any significant changes in the muscle bundle and muscle tissues fibers. We check the histopathology after repeated administration. As you can see that as compared to the control solution and hydrogel formulation, the product has significantly reduced CD31 and Ki67 cell numbers, which actually represents that these are the tumor cells, and these tumor cells vanished away after the treatment of for 21 days. As well as the Caspase-3 and PARP cells, which are actually the tumor cells, their number was significantly enhanced in this product formulation, which shows that the apoptosis of the cancer cell, it takes place with the formulation. We then use nano carrier lipid carrier for the treatment of breast cancer, and this formulation strategy that we have developed, it was also published in International Journal of Nanomedicine in 2020. We prepared this formulation. We somehow able to reach them in the bloodstream tumor environment, and just they disband over there, releases the entrap this miltefosine. Miltefosine is actually a drug of choice for the treatment of leishmaniasis. However, it was initially used as a tumor treatment, specifically in the breast cancer. So we re-evaluated this drug for its treatment, and the results indicated that the tumor volume, tumor size was significantly reduced with the maintenance of the body weight, no significant changes. We also prepared nano cargo of the topotecan for the treatment of skin and colon cancer. And as you can see that these nanoparticles, when they were checked in the tumor-bearing mice cell, they reach over there by using the EPR effect, and they disband within the system. And they are actually, as most of you know, that topotecan and irinotecan, they are topoisomerase 1 inhibition, they causes it. So the tumor cell nourishment stops, and they are no more able to have their effect. There are certain limitations associated with the nanomedicine and, of course, nanotechnology. One of the problem is the design and development. You can see excellent and high quality technologies you need to develop when you prepare those nano formulation. In our lab at Quaid-e-Azam University, with the help of the NRPU and Pakistan Science Foundation, we have got some technological advanced machines which we can use for the preparation of those nanoparticles as well as characterization of those nanoparticles. However, since this is not very common, not every university and every institution has this facility, so that is actually one of the limitation and challenges need to be addressed. We have biopharmaceutical aspect. We do not know that when we prepare any nanoparticle formulation, what behavior it could result when they are administered via any particular route of administration. So these are some biopharmaceutical aspects of any nanoformulation which need to be investigated. There are interaction of the nanomedicine cell with the biological components of the body, for example, serum protein and the complement system, which sometimes consider these nanoparticles as foreign agents, and you see the process is very difficult to handle. The tumor targeting in some of the cases is very problematic because those tumors, they rely somewhere deep in the brain or some part of it. So these nanoparticles, to localize it over there is sometimes challenging. Safety of nanobiomaterial. Some of the nanoparticles, for example, the polymeric lipid nanoparticle or lipid nanoparticle, they have so small particle size that they time cross the barriers of the brain and may reach the brain and may alter the process. So in this particular case, it is highly important to be very curious when you prepare those nanomedicine, and the dose of nanobiomaterial is of course very much important, which need to be rightly calculated for the animals, and then you see the calculation of those dose should be promoted to the upper level. This is my research team at Quaid-e-Azam University. Some of my students, they are already graduated. Saba and Sebga, they are working on various cancer, including the small cell lung cancer, hepatocellular carcinoma. HEC has generously, give us a project for targeting the hepatocellular carcinoma via the National Research Foundation, and we work on scale melanoma and breast cancer as well. Conclusion of this this talk could be that the nanomedicine is actually the rapidly growing area to target the tumor situation, and it is very important to have the site-specific delivery of the drug, and it is highly important that these nanomedicine-based deliveries or targeting system, they may be used for the early detection of cancer, like in the skin cancer or maybe colon cancer or lung cancer. So these need to be rightly promoted. I want to acknowledge the National Research Foundation of Korea for giving me a project to have this studies, accomplishing these studies. I'm very much thankful to the Higher Education Commission of Pakistan because they have provided us more than 25 million rupees in PKR to have, generate these sort of the result. And to rest of my colleague, my students, or department, this is my student, they obtained for the Pakistan Academy of Sciences Gold Medal. This is the award that I was given by the Higher Education Commission in 2019. I'm very much thankful for the audience and giving me your time. And I will be very happy if there is any question. Thank you.
Yes. Thank you, Dr. Baglam. Our question session will be after all in presentation.
Thank you, Dr. Fakhruddin, for your presentation on cancer nanomedicine. Ladies and gentlemen, please allow me to introduce our next speaker, Mr. Ghulam Mujtaba. Mr. Mujtaba is the manager of the Department of Pharmaceutical Services, SKM, Peshawar. With an impressive background holding MPhil and BCPS, he has more than 9 years of working experience in hospital pharmacy with expertise and specialty in critical care pharmacy. Today, he will be sharing his thoughts on the topic, the future of clinical pharmacists in multidisciplinary oncology teams. Ladies and gentlemen, please welcome Mr. Ghulam Mujtaba as he takes the stage.
Yes.
Hello, thank you very much for the nice introduction. So we are going to discuss the future role of clinical pharmacists in the MDT teams, which are usually called multidisciplinary teams. These are the learning objectives of today's talk. So we are going to discuss the concept of MDTs, the roles of different roles pharmacists play in different MDTs. Then I'll share our Shaukat Khanum experience. Then I'll conclude my talk. So, thanks to Dr. Fakhr. So now we know the burden of cancer is increasing each year. So with that, a plethora of new anti-cancers are being introduced into the market. And with that, the treatment of cancer, it becomes more complicated. It's a good news that we have a newer and newer armamentarium of treating cancer. But with that, it makes the treatment more complicated. So with that complication, like if we discuss about the CAR T cell therapy, which is a sort of innovation in the treatment of certain cancers, CRS, which is cytokine release syndrome, it's a common complication. So around 40% of the patients who go through the CAR T cell therapy, they end up having CRS. And out of those 50%, around 10%, they end up having this severe CRS with mortality of 1 to 10%. So one thing more, the number of indications per drug, they are also increasing. Like pembrolizumab was introduced in 2016. It was approved by FDA for the indication of metastatic non-small cell lung cancer. And now pembrolizumab around, after 7 years, is it got FDA approval for more than 12 cancers. So it makes the treatment of cancer complicated. So where does the role of pharmacy or oncology pharmacy lie? So, we discussed that it's a complicated care. So, along with that, there are certain toxicities or adverse drug reactions. It is important that we document these ADRs, and, there are institutional guidelines to manage these sort of adverse drug reactions. And all, the literature tells us that the pharmacists play a key role in designing of these institutional guidelines. So we have a sort of question. So in your view, which of the following should not be the role of oncology pharmacists? So dose verification, is it the possible role of oncology pharmacists? Yes or no? Yes? Okay. So green is yes. Dispensing of drugs. Okay. Patient counseling. Yes. Patient registration and booking. थोड़ा जोर से बोलें पता चले, वरना कुछ लोगों से करवानी शुरू कर देंगे कुछ हॉस्पिटल्स में. Okay. So we need to understand what are multidisciplinary teams. So basically, MDT is a group of health and healthcare staff. They are from the different professions. They work together to achieve a common treatment goal for particular patients. And these treatment goals, they are individualized. So usually oncology teams, they consist of oncologists, hematologists, surgeons, specialist consultants like pulmonologists, nursing staff, pharmacists, microbiologists, radiologists, pathologists, and sportive staff. So we are only going to discuss about the pharmacists. So when I, looked into the literature, so there is abundant literature, although these are not controlled studies. Most of the studies are retrospective, are surveys done to assess the role of clinical pharmacy in the provision of care. So, when we go through the, in the upcoming slide, we'll go through the details of these studies. So we have another scenario. So in your opinion, which ones of the following could be the possible future roles of oncology pharmacists? Independent prescribing of anti-cancers? Yes or no? Yes? Who said that? Okay. So prescribing supportive medications post chemotherapy. Yes. Okay. Independent clinics for oral anti-cancers. Yes or no? Yes or no? No. Okay. Advising patients on the prognosis of cancer. Okay. So interestingly, we'll look into the literature and we'll come back. The first role is, when I was searching the literature, so this was the first role that came up, follow-up service. So this is the evaluation of clinical pharmacist follow-up service in an oncology pain clinic. So basically, they performed a 10-week follow-up service in a pain clinic. This follow-up service was provided by the oncology pharmacist. And when you see the results, basically 44 patients were assessed in the follow-up clinic, and 3 services or roles were provided through this follow-up service. The first role was interacting with the healthcare professionals, making alterations to the patient's medication regimen, and organizing refills, right? And, along with that, the team members were asked to assess the role of pharmacists. So they were asked, like, were they satisfied with the role of pharmacist provided in the clinic or not for this particular follow-up service? And all of them, they said yes. Pharmacist, plays a very important role. So next role is resolution of drug-related problems. When we look as a pharmacist, when we look into the prescriptions, there are certain elements that needs to be checked to make sure that the prescription is appropriate. So usually these elements come under the umbrella of drug related. If there is a problem, our pharmacists, they intervene those are. So these problems are called drug related problems. So in the first study, the role of pharmacists in the multidisciplinary approach to prevention and resolution of drug related problems. So what they saw, 102 prescriptions were assessed prospectively. Out of those, 52 prescriptions had some sort of drug related problem, and total interventions out of those 100 prescriptions, total interventions were 200. 90% of those prescriptions were accepted by the physicians. The third role is prevention of drug interactions. So this is another interesting study. So 75 patients were included. 30, almost 41% of these 75% patient prescriptions had some sort of drug interaction. So most interactions were among the drugs included in the patient usual care, like they were, with cancer, there are certain supportive medications are also prescribed to the patients, like antihypertensives, medications for the management of diabetes. So majorly interactions were with the cytostatic agents, antiemetics, and antidepressants. The hospital pharmacists intervened on 20 occasions, 35% of those. These interventions mainly focused on the recommendations to modify or discontinue drug prescription and were followed in 94% of the cases. So, we know that, for example, oncologist or the primary care provider who might be the hematologist or oncologist, they are not supposed to remember each and every drug interaction that an anti-cancer is going to have with all of the other certain medications. No, this is the service that is usually provided by the pharmacy staff, by the oncology pharmacist. So participation in ambulatory care. So availability and role of clinical pharmacists, ambulatory neuro oncology was assessed. Out of the 65, these were the member of this society, Society of Neuro-Oncology. They were asked to, answer to certain questions to assess the role of pharmacist in the neuro-oncology clinics. 52 were clinical members, of these society, of these 52 clinicians, the main were physicians, 88%. Of these physicians, most were in academic practice. So what they reported, they saw that despite having busy clinics, only 10% of the, so what they saw was the pharmacist provided 2/3 of all their patients. The care was provided, some sort of care was provided by the clinical pharmacist. And when they were asked what were the top 3 roles, so first role was dose modification, practice guideline development, and management of the supportive medication. So the last medication adherence is the next role. The impact of pharmacist-led oral anti-cancer clinic on medication adherence and laboratory monitoring. So when we look at the results, a total of 189 charts were analyzed with 134 excluded and 55 included. Independent sample, t-test was applied. Okay. So when we compare the results for patient adherence to lab monitoring, there was a statistically significant improvement between phase 1 and phase 2 for patients on abiraterone and enzalutamide. However, for patients on ibrutinib, there was a slight decline in lab monitoring adherence between phase 1 and phase 2. So those of you who practice oncology in their institutions, they know that adherence is a common problem, especially with the oral chemotherapy drugs. So the literature tells us that 40 to 60% of the patients, they do not take their medications as prescribed. We are talking about oral anti-cancers. So when the pharmacist was included into this equation, this adherence significantly improved. So at the last, we are going to discuss 2 surveys. This was done to assess the role of oncology pharmacy. It was a global survey. There 3 important roles came up through this survey. First was the oral chemotherapy programs. Pharmacists were, included into the oral chemotherapy programs. Second was provision of medication therapy management. Under this, there are 6 types of different services they are provided by the pharmacist. Starting from the review of prescription till the follow-up of these patients, they all come under the umbrella of medication therapy management. And the last was CPAs, which are called collaborative practice agreements. When we look at the literature or the case studies, pharmacists are included into a practice agreement with physicians or nurses, where they provide some sort of services. So the next survey, it was done by the European Clinical Oncology Pharmacy. It is an association. So what they did a pre-conference or pre-meeting survey, and then they concluded the session and did another survey. So we are going to discuss these 2 surveys. The first survey, where they, it was done pre-symposium or the pre-meeting survey. So these are the areas which all of the members and the delegates coming to this meeting, they considered are important and have important, role in the future of oncology pharmacy. So one of them was drug shortages. So I was looking at a study. It was a European study. It was done, a survey-based study was done in almost 1,700 different hospitals. So out of these surveys, 70% of those hospitals had some sort of drug shortages. Out of those, 30% had shortages of anti-cancers. So it becomes a dilemma when you have a patient who is, potentially treatable, but you don't have a treatment. So my colleague Abdul Wahab is going to discuss in detail regarding these the drug shortages and possible mitigation strategies. So second was establishing partnership with the national and international organizations, pharmacists' role in the multidisciplinary teams. So the topic that we are discussing, it was the third most important topic that they considered. is going to be the future of our oncology pharmacists. So at the end of the session, they concluded the session, and these 4 areas were sort of considered the area of high importance, which are going to significantly impact the future of oncology pharmacy. So the new pharmaceuticals, as Dr. Fakhr was telling us, that there are many new pharmaceuticals that are being introduced into the market each year, and many of them are in the pipeline. So with that, it becomes a challenge for our pharmacists. So, they have to play a very proactive role. Improve clinical management of the cancer patients, like we discussed, participation in the medication therapy management, CPAs, and resolution of drug-related problems. They all come under this clinical management of the cancer patients. So third was implementation of the multidisciplinary working groups. So all of them they considered pharmacists should be an integral part of all MDTs. And the last one was technological advances. So this is, most of the dispensing and the quality checks in the future, they are going to be replaced by the technology somehow. But, technology cannot replace your brain, your level of knowledge. Ultimately, the role of the pharmacist is going to be shifted from the drug-oriented to the sort of more direct patient care. So with that, I'm going to share our Shaukat Khanum experience. The roles that we were discussing are all provided by our oncology pharmacy teams. So a newer thing for us in Peshawar, it is being done in Lahore previously as well. So our pharmacists and resident pharmacists, they started going into the oncology clinics under the supervision of oncologists. So there were 2 important roles that they played into the practice. One was counseling of patients on the possible toxicities of anti-cancer. It's a common protocol when a oncologist going to suggest the possible treatment to a cancer patient. They usually go through all the possible toxicities that the patient might experience while going through the treatments. So this service was provided by our pharmacists. The second was designing patient education leaflets of different chemotherapy regimens. So with that, I would say that oncology pharmacists will be more involved in direct patient care activities in the future. They are going to be at the front line of oncology care in the future. Thank you.
Thank you, Mr. Mushtaba, for your insightful speech. A leader is the one who knows the way, goes the way, and shows the way. Having said that, I would like to invite our next guest speaker, Dr. Inamul Haq. Dr. Inamul Haq is a graduate of Gomal University and did his PhD from University of Peshawar. Currently, he is working as Deputy Director, Pharmacy Services Medicine Coordination Cell at the Directorate General of Drug Control and Pharmacy Services in Health Department, Khyber Pakhtunkhwa. He will be presenting on the topic Policy Implementation and Challenges, a case study of the telemedicines in selected Khyber Pakhtunkhwa public sector hospitals. Ladies and gentlemen, please welcome Mr. Inamul Haq.
Bismillah ar-Rahman ar-Rahim. Thank you so much for giving the opportunity to present the experience of the health department on this forum. I must say that the presentation is not data driven as the earlier clinical and research intelligence I have presented. This is an experience of the health department, and hopefully this could be giving you an insight for the future work if somebody is interested to work in the telemedicine. So I'm Inamul Haq, and I'm working as Deputy Director at the Pharmacy Services at the Health Department, Directorate General Drug Control. Before going into the detail of this presentation, I must say that the digital health market was expected to grow at 9.7% in 2020, having a volume of 201 billion, while the COVID-19 has totally changed the paradigm of the digital health or the e-health or telemedicine. And now it is expected to grow at a rate of 24.52% to a tune of $48.3 billion in 2025. By application, it will have a great impact on the oncology and the healthcare providers as end user. The outline of this presentation will be the introduction to the telemedicine project of the KP, the objective and its need, the business model, the scope of the telemedicine project KP, the project timeline and implementation and challenges. Actually, the telemedicine project was initiated with the name of piloting innovative ideas to address key issues of the Khyber Pakhtunkhwa. Among all others, telemedicine projects like the telefarming, the tele-skills and others, telemedicine was initiated. Initially, the telemedicine project was selected for the 5 districts based on the demographic and geopolitical condition and geographical conditions of this province, which include Nowshera, Sawabi, Karak, Batagram, and Chetral. The authority for the sponsoring and execution was lying with the piloting innovative ideas, sustainable development units, planning and development department, Khyber Pakhtunkhwa, while the implementation, operation, and maintenance was lying with the health department. The proposed project was allocated from the umbrella project at a cost of Pakistani rupees 95 million, in which 65 million were allocated for the equipment or the telemedicine equipment. The total volume of the umbrella project was 1,056 million under the ADP scheme of 2016-17. The objectives of telemedicine project were to improve the basic health services by connecting people of far-flung areas with qualified consultants of tertiary healthcare through AI-based modern ICT and ensure healthy lives and promote well-being for all at all ages. To establish 5 telehealth clinics, as earlier said, in the selected districts, and further upscale and generalize them, and to provide healthcare economically and conveniently to the patient visiting these DHQs or RHCs for medical consultation and specialist advice, and to provide simple, low cost, and scalable telemedicine or telehealth solutions. There were some other relationship with the sector objectives regarding to these sustainable development goals or millennium development goals, which I have highlighted, to ensure the healthy lives and promote well-being for all at all ages, particularly for the selected areas, and then to generalize it to the total KP, and build resilient infrastructure, promote sustainable industrialization, and foster innovation, and specifically in the health department. It was also having in relevance with the Vision 2025 of the stable economic Pakistan and its economic stability. And it was in line with the National Health Policy 2001 to improve the health sector by the health sector investment, which are viewed as part of the government poverty alleviation plan, and priority attention is accorded to the primary and secondary sector of health to replace the earlier concentration on the tertiary care and to improve the good governance. The need for telemedicine was basically based on the far-flung areas, are, as earlier said, that the geographical conditions or the economic condition of the people of KP. So the main aim were to improve the basic health services in remote parts of the KPK using ICT and to ensure the WHO Millennium Development Goal of Health for All in KP, to reduce the burden on medical consultations and specialist advice, and to improve the patient referrals for further treatment. Initially, the telemedicine project was started in these five selected districts, along with a mobile health clinic. The hub facility and coordinating center was established at the Police and Services Hospital, Khyber Pakhtunkhwa, Peshawar. Telemedicine program was basically consisting of two parts. One was the hub, which was established at the Police and Services Hospital, and the spokes are the satellite outreach centers, which were established in Nowshera and different other districts. The purpose of these spokes were to shortlist patients for consultation, to book their appointment on request or immediate consultation, to send case details and images, to join them on video consultation for the specialist advice, and to receive prescription. The business model of the KP telemedicine project was public partnership based. Initially, there were multiple hurdles in selecting a consultant for this purpose, but finally, a Canadian-based organization, Tech for Life, was selected, and they initiated this project. The recommended specialties which were included in the telemedicine project were general medicine, obstetrics and gynecology, the ENT, ophthalmology, psychiatry, dermatology, radiology, cardiology, and pediatrics. These telemedicine services were provided, which included to store in forward consultation, live consultation were there before between the patient and the consultant. Image reporting was done through digital radiology equipments and accessories. Online scheduling was done. Cloud-based solutions were provided to the patients. Web and mobile-based applications were incorporated to improve the health of the patient who were seeking consultation advice. Low bandwidth connectivity was offered to improve the process of this online or telehealth function. Reporting module was established. Easy integration with electronic module record, electronic medical record were incorporated, and simple hardware integration was done. This was also, the software was compliant of the HEPA and HL7. These telemedicine equipment were included in all the operations, which include the digital journal examination camera, the digital multi-purpose camera and scope, digital ENT otoscope, digital otoscope, digital video otoscope camera, digital ophthalmoscope, digital nasopharyngoscope, digital camera and illumination system, the digital interactive stethoscope, or picture archiving and communication system. We can also call it as a digital radiology apparatus. That also included digital stethoscope, vital signs monitor, digital Holter monitoring system, digital retinal camera, and digital ultrasound probe. Along with it, a satellite portable teleclinic was also incorporated, in which was the basic aim of this portable teleclinic was to use them in time of a disaster or a pandemic. There were certain challenges during the implementation of the telemedicine project. Initially, the procurement of or the hiring of a consultant for the telemedicine project was a huge problem, and that was overcome because multiple tenders were floated, and then multiple tenders were floated, and no one was selected. However, finally, the Tech for Life was selected, which were having some limitations, but that were overcome. It was decided that the same will be overcome later on. Then awareness and publicity in the people of KP, particularly in the far-flung areas, was also a major challenge in the implementation. The proposed facilities were also a challenge to select that which district should be selected in this project or to be removed. Medical specialties offered were also limited due to the availability of the digital equipment, training of the staff, demand and supply of the analysis or reports, and satellite or internet connectivity, particularly in the far-flung areas. Challenges were including the infrastructure limitations. There were no proper infrastructure, particularly in the desired far-flung remote areas which were selected for the telemedicine project. Data privacy and security is another issue, was another issue, and awareness and publicity, as earlier said, that the patient or the people were not aware of to utilize this telemedicine project. Capacity development and training of the staff which were selected to pilot this or to start this telemedicine project. Pilot project scalability was another issue due to the economic and other issues related with the government. Patient social behaviors, there were certain norms and social barriers which were not allowing the patient to come and get the facility of their telemedicine clinics. Clinical setups and clinical limitations were also there. Public sector governance is another issue in implementing such projects. Political will and economic stability is, like other issues, is another. I must say that this is the largest contributing factor that we could not generalize or upscale that project, and along with that, sustainability. Telehealth reimbursement were also issues in the continuing this project. Patient and doctor adaptation and engagement were the challenges in the telemedicine project. Connectivity and offline operations, particularly in the far-flung areas, and electronic medical record integration was also a challenge in the telemedicine project. The last but not the least is the legal framework or the availability of laws which governs, or the act which governs the telemedicine was the major issue in continuing the telemedicine project in KP. Thank you so much.
Thank you, Dr. Inamul Haq. Ladies and gentlemen, allow me to introduce our fourth speaker of today's session, Mr. Abdul Wahab Afridi. He currently holds the position of Deputy Manager, Pharmacy, SKM, Peshawar. With 13 years of experience in the field of hospital pharmacy, he has established himself as an expert in his field. Throughout his career, he has performed and give presentations at international and national conferences and forums, displaying his vast knowledge in the field of oncology pharmacy and procurement of anti-cancer drugs. Ladies and gentlemen, I would like to call up on stage Mr. Abdul Wahab Afridi to present on the topic overview of different strategies to mitigate the shortages of anti-cancer drugs. Put your hands together for him.
Thank you, Ms. Rimsha, for nice introduction, and Assalamu alaikum to everyone for this session. Today, the session of mine is regarding the strategies to mitigate the shortage of anti-cancer drug. As you know that nowadays, we are after the COVID-19 and after the rise of the dollar prices, we are all facing the shortage of not only the anti-cancer drug, but all kind of drugs we are facing. You all know about that. So moving to our slides. First of all, I have not received any financial or commercial funding or support for today's session. No specific conflict of interest, and then I have no financial relationship to disclose. The objective of my presentation is explain the most recent trend in cancer drug shortages and evaluate progress towards solution. Describe how recent manufacturing and drug quality trends to overcome the drug shortages, and design cancer drug shortage mitigation strategy to minimize patient safety concern. So first of all, come to the introduction. As you know, the basic note of the supply chain is that how the raw material comes to the manufacturer, and after manufacturing the drug, it goes to the distributor. From the distributor, it goes to the wholesaler, and from the wholesaler to the hospital. And so it's the total supply chain, that how the medicine comes to the patient. So imagine if mostly time we can face this time of situation that in surgeon running of anesthetic drug, mostly time we are facing this kind of situation. Or sometimes the cancer patient cannot get life-saving chemotherapy. I have tried to include my 2-minute video in this session, but unfortunately due to some time constraint I couldn't. I have intervened some patient in which I have seen their situation, that how they are doing hard work to find out their medicine. Like recently, I have intervened one patient, and he was looking for his baby who was ALL patient, and was simple tablet markeptopurine, which was easily available before, and he was searching for the tablet markeptopurine. So it's very worse situation for the patient, and also for the doctors and for the pharmacist. Same like doctor looking for the basic sensitive antibiotic. This is the also most basic dilemma which are facing by the doctors due to the multi-drug resistance antibiotics. And we are already there. So come to the definition. As per the FDA, a situation in which the total supply of all clinical interchangeable version of an FDA regulated medicine is inadequate to meet the current or projected demand at the user level. And as per the ASHP, American Society of Health System Pharmacists, a supply issue that affects how the pharmacy prepare or dispense a medicine product or influences patient care when prescriber must use an alternative agent. So come to the current trend of the drug shortages. I have included some slides which are taken from the University of Ohio, which it is a study of 2001 to 2023 in the America, that how the number of new drug shortages in the United States. Secondly, slide contain that it's according to the route of administration, that how much of them was injectable and how much of them was non-injectable. This data was also from the 2021 to 2023. Third slide contain the according to the classes of the drug, that antimicrobial was 13.6, chemo was 8.1, and central nervous system was 16.2, same like the other medicine. Now, this drug shortages is not only reported in the America, it is also reported in the Europe, which I've included in next slide. Like this, it has different data I have taken from this website. Like this, Europe countries have different percentage of the drug shortages, in which 66% was in Italy. Same I have included our Pakistani data. I have included, which was taken from the BMG journal, and which our oncology medicine shortages was 54%. Now, what's the number mean of? So this means that new shortages increasing, ongoing stretches not resolving. Basic product for patient care are short in the market, and also our local anesthetic, cancer medicine, antibiotic, opioid, antiemetic, these all are shortage nowadays in local market. So what is the element contributing to an interruption in the availability of the medicine? There are some element like manufacturing problem and regulatory issues, voluntary recall. Like voluntary recall, recently you have seen the voluntary recall of the intravitreal Avastin, which has also faced an issue by the oncology patient also, because they have recalled the total generic drugs. Same like raw or bulk material supply issue, alteration in the product formulation, limited drug production supply, industry consolidation, manufacturing decision, natural disaster, fragmented demand, and shift in and gray market or poor inventory control and non-traditional distribution, restricted drug product distribution and allocation. Now coming to it is also the Pakistani data in which different causes of the medication shortages was according to percentage wise, like there was 9% was due to the absence of updated regulation, government regulation, import issues, same like 9% was registration issues, manufacturing, and some was absence of updated government regulation, discontinued due to low cost, low demand, increased demand, and the most was 31% was absence of updated government regulation and registration issue. Mostly the shortage was due to regulation issues. Same like this is the FDA data, which have shown us that in 2022, the drug shortages was mostly 7% was due to the raw material, 2% was the logical due to legal regulatory, 8% was the manufacturing, and 12% was due to supply demand issue. So what is the impact of these drug shortages in our patient? So first of all is the hospital expenses also increasing, same like goes to the safety risks of the patient. We have also go for the supplies of the alternative drug. It's also lead to the patient stress and strain and impair patient care. This is also a review article which has shown a different impact of medication shortages on patient health. In this, you can see what is the patient-specific view. Same like there is some patient-specific views and also the physician views and healthcare professional views. Coming to the mitigation strategies, how that we can strategies for the drug shortages. So first of all, there is some regulatory changes which we can lead to some mitigation of the strategies to drug shortages. Second is the diversing supplies. Third is the stock billing. Fourth one is the telemedicine, and fifth one is the drug repurposing, and sixth one is the research development. So we will go one by one these mitigation strategies. So first of all, come to the regulatory changes. In regulatory changes, we need update the role of the DRAP and policies for the easy registration of drugs, import and renewal process for anti-cancer medicine. Second one is DRAP should take immediate step to increase the availability of these medicine through multiple supplies registration. To increase local production of raw material and oncology medicine, DRAP should give incentives to the manufacturers. Fourth one is to implement current good manufacturing practices. The quality of locally produced medicine need to be improved and strict regulation from DRAP are needed. And fifth one is need for drug shortages task for development to identify cause and the solution at the national level and in the developing countries. Coming to the next slide, diversing supplies. So what's mean diversing supplies is a crucial strategy for mitigating drug shortages as it reduces the dependency on a single source and provide greater resilience in the pharmaceutical supply chains. So if we have to go to check the supplier portfolio assessment and also identify alternative supplier which have good supply, evaluate supplier capabilities that he can supply the medicine. Also, we have to maintain safety of the stock, same like collaboration and communication with the supplier and other regulatory issues. Contingency planning, we have to develop a contingency planning, and also a scenario planning also we need. Same like for the stock billing, mitigate drug shortages through stock billing of medicine can be a challenging and complex process as it involves ensuring adequate supply while also managing expiration dates and storage condition. And there should be, we have to identify critical medication which need to be shortage. Also, we have to inventory management, collaboration and communication with the healthcare provider and also with the supplier, regulatory compliance, public awareness, storage facility, regular review and update public awareness, supply chain resilience, and emergency preparedness plan and public awareness. Third one is the telemedicine. As you know, that nowadays telemedicine mitigation drug shortage through telemedicine involve leveraging technology and remote healthcare practice to ensure that patients have access to the medication they need. By incorporating these strategies, health provider can use the telemedicine to help patient manage their medication effectively and mitigate the impact of drug shortage. So this is the step that if we do telehealth medication management, remote medication conciliation, medication therapy management, telepharmacy services, teleconsultation for medication substitution, patient education about their drug shortages and if there is any alternative to their medication, real-time drug shortage monitoring. If we tell to the patient that the drug is going to be short, and also there is any alternative source for this medicine, and also collaborative healthcare team. This is, I can show the example in next slide, which we are doing collaborative healthcare team. So like drug repurposing, what is drug repurposing? Mitigation of drug shortages through drug repurposing can be valuable approach to address the challenges associated with drug supply disruption. Drug repurposing is also known as drug repositioning or reprofiling, involving finding a new uses for existing drugs. Drug repurposing offer a promising way to address drug shortages, and especially for life-threatening or rare condition where the development of new drug is time-consuming and expensive. By implementing these strategies, healthcare system and pharmaceutical companies can make better use of existing sources and improve patient access to essential medication. At the end, research and development, this is also some strategies in research development due to also lead to strategies to mitigate the drug shortage, in which forecasting and early warning system, diversification of supply chain, life cycle management, regulatory flexibilities, stockpile creation, and patient-centric approach. Now come to the case studies, which was presented in America in September 2017. A storm hit the American state, which was called Puerto Rico, and creating a shortage in the United States, a significant number of critical medical products, like including human drug, in which normal saline and sterile water for injection were subjected to end shortages that last several months. And the FDA worked with drug manufacturing to approve new facilities and temporarily import product from other countries. The FDA also used data provided by drug manufacturer to extend expiry date and issue guidance to provide alternative treatment and conservation strategies. By increasing supply, managing existing inventory, and communicating frequently with the public, the FDA was able to partner with drug manufacturer to protect the public health and to provide a timely and impact response to Hurricane Maria, which was the storm hit the Puerto Rico. So how they manage this situation? So come to the next slide, where we stand in competitiveness. Okay, so I have put a case of recently the recall of the Avastin, as you know better in this, that how our regulatory bodies control this, and how the patient feel in the market about, and also how the oncologist feel the situation that their patient not getting the medicine intravitreal Avastin, which are used in different type of cancer. So they have been for also in all type of treatment. They should be for the ophthalmic treatment, but they should not need to be for the other treatment, due to which mostly patients suffered. And what do we, Shaukat Khanum Trustwide, what we are doing? So when we have faced two type of situation, like in first one was in COVID-19, and second was in the recently drug shortage due to drug price. So we have made a committee, anti-cancer drug shortages committee, in which different type of consultant. We have a medical oncologist, radiation oncologist, we have supply chain staff, and also a pharmacy team. And we have met after every 3 weeks. And in this meeting, we have we have made a graph, in which we can see in next slide, you can see this graph. We have added different kind of chemo drugs, and which show that how much the quantity I have in my shelf, and how this quantity can stock in my inventory, and how much month they can cover me. And in this meeting, we have also discussed with different consultants about that if there is some drugs which are going to be short and it is not able to, we have find, so what is the alternative source we can manage from the other. And instead of that, if some medicine are not able to manage, then we go for the import process on patient need basis or the institutional basis. And at the end, also we need patient education about the patient safety, also about the treatment continuity, collaboration with the healthcare provider, minimizing stockpiling, and preventing harm self-medication at patient mental health. At the end, conclusion is that drug product supply issues are becoming more frequent and remain a major international problem regardless of the cause. The reason for shortage may differ from country to country, but in general, they are the same and each country will face it. So it's not that this drug shortages we are facing in our Asia, as you have seen in last slide, that they are also facing in America, in the Europe countries. But the main tease is that we need proper planning can minimize the adverse effect on patient care, health system costs, prevent problem for establishing into crisis, and effectiveness of information gathering, teamwork, and communication with the provider, government, and patient and administration. So these all lead to all kind of our mitigation of the drug shortages. This is the references, and thank you.
Thank you, Mr. Afridi, for sharing your knowledge and addressing this crucial issue. Your contribution is greatly appreciated. Allow me to begin from the quote of the Florence Nightingale, who was the pioneer of the modern nursing. The very first requirement in the hospital is that it should do the sick no harm. This quote holds true, especially in the context of the safe and effective compounding and dispensing of the anti-cancer treatment, which is very crucial for the well-being and recovery of the cancer patients. Today, it is my privilege to introduce our distinguished guest, Mr. Jahanzeb Khan, who holds a very professional background as a PhD PhD scholar and a lead clinical pharmacist at Hyderabad Medical Complex, Peshawar. With 10 years of the working background, he has worked in different areas as infectious disease pharmacotherapy, medication safety, critical care, and total parenteral nutrition. Mr. Khan has significantly contributed to various tertiary care hospitals, including his role as former assistant manager at RMI Peshawar. Mr. Khan will be addressing on the pressing issue of establishing clean rooms for compounding and dispensing of anti-cancer drugs in various public sector hospitals. Ladies and gentlemen, please join me in giving a warm welcome to Mr. Jahanzeb Khan. Welcome, sir.
Bismillahirrahmanirrahim. Thank you very much. So today I'll be discussing a dire need of establishing clean rooms for safe compounding and dispensing of anti-cancer drug in public sector hospitals. Well, the topic is very interesting, but unfortunately, first of all, I have no conflict of interest. Presentation outlines our burden of cancer, need for clean room, where do we stand, and challenges and solution. The topic is very interesting, but unfortunately, in public sector hospitals, the situation is very grim. Having said that, my colleague Dr. Inam has said the telemedicine project, there is another project, the TPCP, treatment of poor cancer patients project. Before that, there was no system for provision of anti-cancer drugs to patient visiting the public sector hospitals. With this project, we are receiving many of the poor patients who are visiting, and we are providing medicines to those patients. The global burden of cancer, as previously said, is increasing day by day. In 2020, an estimated 19.3 million new cancer cases had been diagnosed worldwide, 10 million cancer deaths, and in 2040, it would be estimated to reach the figure to 28.4 million cancers globally. Burden of the cancer in Pakistan, coming back to home, newly diagnosed cases are 0.18 million and with a fatality rate of 0.1 million. These are the public sector oncology, public and private sector oncology care institutes in Pakistan. In Khyber Pakhtunkhwa, we have Shaukat Khanum Memorial, Benord, INOR, Abbottabad, Institute of Ernam Peshawar, and Sainor. So these, you can imagine the, with this, actually we don't have a data related to the use of anti-cancer drugs in Pakistan. The reason I am quoting this slide is it would be a reflection of the burden of anti-cancer drugs and cancer patients. Need for a clean room. Why clean room is important in any situation or any institute where anti-cancer drugs are involved. As you have in books we have read from the very first pharmacology till the applied nature of the knowledge, that anti-cancer drugs have the potential to carry out the mutagenic activity. They are itself cancer-causing agent. So if you use it without the proper services or without the proper standards, they can cause the cancer to the healthcare worker, or that can pose a significant risk to the healthcare workers, environment, and the patient itself. These are few mutagenic activity which have been reported in although 1979, and from these reports, a need for clean room arose, and it led to the USP 797 chapter, end up with the USP 797 chapter. Liver damage in nurses handling cytotoxic agents, mutagenicity in urine of nurses handling cytotoxic drugs, occupational exposure to anti-neoplastic agents, and self-reported infertility among nurses and pharmacists. As I said, there is no data related to the handling of anti-cancer drugs in Pakistan. Just I have come across with one study conducted by Mariam Azim in 2019, where it was just it has just shown us the burden of Medicaid-related events among the cancer patients, although it was not related to the it hasn't explored the causes of medication-related events. Environmental factor is another problem which must be addressed through adopting clean room practices in hospital settings. Now, where do we stand actually? The absence of legislation is the main hurdle or the main countering factor. Nevertheless, DREP has come up with to some extent developed guidelines and recommendations, but in altogether a different contextual framework. DREP has recently issued high alert medication guidelines regarding which they have included the cytotoxic medication as well, but the context is altogether different as compared to the their handling or their use in healthcare settings. So we need a powerful and implementable legislation that could come up and that could be implemented in a very favorable and quick manner. A new addition into the accreditation standards for way forward is a new addition into the accreditation standards of tertiary healthcare institutions. Oncology unit shall encompass the standard regarding the safe use of cytotoxic drug. It should be incorporated in the accreditation standard of every healthcare institution. Every healthcare institution who opt to provide oncology services must comply to the standards regarding the safe handling of cytotoxic drugs. The standard shall describe the hierarchy of control used to implement feasible and effective control related to the use of drugs in hospital setting. In descending orders, they are engineering controls, administrative controls, and the use of, and at least the use of personal protective equipments. Thank you so much.
Thank you, Mr. Jahanzeb Khan. We greatly appreciate your dedication to patient safety and the advancement of pharmaceutical services. Ladies and gentlemen, the only way forward if we are going to improve the quality of the environment is to get everybody involved. These wise words were said by great environmentalist Jane Goodall, which are highly applicable when we talk about the future of anti-cancer medicines compounding and role of automation in this field. Our final speaker for today is Mr. Shoaib Shamas, who holds the position of Pharmacy Manager at SKM Lahore. Having dedicated past 11 years of his work to SKM, Mr. Shamas has made significant contributions in the field of oncology pharmacy. His dedication and commitment in ensuring the highest quality of patient care safety is evident from his role as a board-certified sterile pharmacist, board-certified sterile compounding pharmacist, and is an expert as an ISO lead auditor. Today, Mr. Shamas will be addressing on the thought-provoking topic, the future of anti-cancer compounding. Is automation going to be the only way forward? Ladies and gentlemen, put your hands together for Mr. Shamas.
अस्सलाम वालेकुम, कैसे हैं आप सब? एंड स्पेशल थैंक टू एवरीवन कि आप लोग यहाँ पे आए और इस सेशन को अटेंड किया, और क्योंकि संडे पे और इस टाइम पे आना इज अ बिग चैलेंज फॉर एवरीवन, राइट? So thank you everyone for that. So moving forward, the main topic of this is the future of anti-cancer compounding, and the main element when we start, जिस तरह start में we have the technology, then we have the processes, then the role of the pharmacist, and the role of the pharmacist in sterile area things. So now it's time for the final refinement in the microscope. So moving forward to that, no disclosure on this. So as said earlier by Mr. Jahanzeb, that this is the complex process. So based on the complexity of the process, there are multiple integrated activities involved in that whole compounding services. Then you have to develop individualized patient dosing as well as the exposure to healthcare workers. And the handling of the hazardous drug is very important. And the last thing is that how to manage the waste generated from the health hazards or the compounding of the hazardous drug. So for moving forward, we need to understand the process. Actually, it's time to understand the whole process, how the drug is prepared from the pharmacy and dispensed to the nursing locations. So whenever the patient came, is come from the scheduling of the patients. Any patient came for the scheduling. Then there is a prescription right by the physician, and then the role of the pharmacist, as mentioned in this part, and then the administration of that medications. So we are going to talk about the third point. And while talking about the third point, there is opportunities in the prescriptions as well as the nursing side. As you see, there is a CPOE system that is called the computerized physician ordering entering system that helps the physician to write the medication in an appropriate way. And then the same is the smart infusion pump technology. It's helped the nursing to administer the medicine in a very precise manner, and that is integrated with the whole system. So while moving forward for the medication preparation at the level of the pharmacy, these are the multiple steps that are involved in the process. First of all, the prescription verification by the pharmacist, and then converting that prescription into an order, that how many vials are required, what are the labels, thing like that. And the third one is that's called the staging, that every element that required in the prescription is physically present there. And then is the reconstitution of that product, and the medicine is prepared, and then it's labeled and dispensed to the respective locations. So this is the journey of the drug entering into the pharmacy and then going out to the nursing locations. Meanwhile, these are the three major elements that have the process in the pharmacy, like sterile area requirements and the prescription verification and the equipment. While talking about the sterile area requirement, so now we understand the process. Now we are going to apply the technology into the processes. Then we have the dedicated room facility for the sterile area. And when we have the dedicated room facility for the sterile area, then you have the building management system. How this will work integrated into your processes, that when you have the dedicated room, and then you are going to apply the building management system, it will integrate in the live performance activity of your area. Then you have the live area testing and the PPEs control system. So this is the area, as you see, this is preparation of the normal drugs, this is the anti room, and this is the USP for the hazardous drug, and this is the area where you store the medications. So how you understand the area is compliant to the processes that are required by the standard requirements. So you have the building management system for that as well. So it will guide you that area is safe for the human as well as for the product that is going to manufacture that. Is give you a live particle count into the system. Live area is secured, safe for human as well as the product. That when you are going to prepare, the particle count should be certain level. So it will give you the alert that particle count is high. You're not going to manufacture any, prepare or compound any medication in the area. So this is integrated system with the pressure controls, temperature, humidity, and ISO classification. Live, you can see a live into the system. Then this is the testing. As you see, this is the live testing, that when pharmacist or the technician prepare the medications into the area, so they develop a sort of a kit that identify any contaminant into the surface area. And when the contamination is, for example, if the MTX is dropped on the surface of that area, and that is going to hazardous exposure to the healthcare worker as well. So for that purpose, they develop a kit. But the limitations of that kit is it can identify specific few type of chemicals. So this is the limitation on that as well. But this is used internationally. So this is one of the technology, thanks to COVID, that technology is used in one of the hospital in Malaysia. There is a study on that as well. So that is very important impact, that whenever the healthcare workers are going to handle the hazardous drug, he or she must be protected from the exposure of the hazardous drug. So this system is in place. So where anyone can stand in the front of that, is identify that the human or he's not fully equipped with the PPEs. So it will give you alarm that XYZ is not appropriately wear the PPEs. So he or she must wear the PPEs for the further processes. And this is practically implemented in hospital in Malaysia as well. Moving forward, this is, so we understand the area requirement of that. Now this is the prescription. So pharmacists, this is the way that this is a manual prescription of any anti-cancer drug, any protocol of that can be prepared on that. So shifting to the electronic system, and then system is integrated with a clinical decision support system. This is the integrated system that comply and regulate the processes as well as guide you that, for example, if a patient is have the medications and that is have the low lab values, so cannot be given, so need to adjust the dose. So the same way is guide the pharmacist as well as the physician, that you have to decrease the dose or increase the dose based on that lab values and elements on that. So third point, that is related to the equipments. That is very important because it's, so I'm not talk about the cost of the things, but I'm talk about the future of the compounding area. So based on that, we have the biological safety cabinet. Simple, you understand that is a, for the hazardous drug, you have to class 2 B2 product on that. Then you have the measurement equipment that tell the worker or the healthcare person that medicine is going to prepare in a very right manner or not. So this is the gravimetric analysis, that system assess the weight of the medication in the syringe or the drip and guided you that the volume you drawn from that syringe is inappropriate and should be, dose should be corrected on that. And the same is the volumetric equipment that guide you the volume. For example, the volume of the syringe is 2 ml and you draw 1.5 ml. Then straightaway guide you, you have to draw 0.5 ml more on that as well. The last one, we have the clinical, we have the CDSS, that is a closed system transfer devices as well. So this is the IBX workflow management system that can add into your biological safety cabinet, that took the picture of the vial as well as that generate the gravimetric, volumetric and barcode medication verification of any medicine that is prepared into your system. And then is all in one system, means you have drug labels, drug barcode system, verification of a gravimetric and the volumetric analysis. And the remotely verification of the pharmacist. Pharmacists can remotely verify anywhere in the process. Then the documentation in the cloud system. This is one of the remote system, workflow system to remotely validate the documentation of a manual IV administered process. So it's a non-invasive, not added into the your biological safety cabinets. It's a barcode verification, high resolution image that placed outside your facility, and the process is that. And the third good thing is that it has hand-free voice recognition system into that. So this is one of the thing, no one can understand the process while you're mixing any medication. If the errors happen, no one knows. So accuracy is very important. Based on that, it will calculate the volume required to draw from the drip and to add into the next level. It will guide you, and as you see, the precision on this equipment as well as it will automatically transfer and decrease the workload of healthcare worker. Now, after the biological safety cabinet, the new technology is automation in the compounding. So see, we have the robot, we have the manual system, then we have the robotic arms, and that goes cleaning of self-decontamination of the area and syringe and file container of that, and to minimize and maintain the ISO class 5 in the area while processing the activity. This is one of the system that is the IV preparation camera interface. This is a simple tablet that integrate into your system, and the process activity is that is fit in any design of the system, and is take the pictures remotely verification and remote checking of the processes. So this is one is the closed system transfer devices. Sorry. So closed system transfer devices are devices used mechanically prohibit the transfer of environmental contaminant into the syringe and escape of hazardous drug vapors concentration outside the system. What is this? It's actually a needleless system in your processes. There is no needle involved in the whole process from the preparation till the administration of the medications. So it equalizes the pressure that the negative pressure vial and the positive pressure vial. Same is the case, minimize exposure to the healthcare worker because there is a minimal exposure in that. Because there is no sharp injury, no needle stick injury can be happen with that at the level of preparation or the administration. This one is conversion of the barcode into the QR code system. Barcode will give you a one-step process that medicine is prepared. This is the medicine. You can scan it. Okay, done. But with this one, we are going to this from this to this one that even save the whole process from the appointment till the administration that contain all the information in just one QR code. So moving forward, how SKM think about this? Can we have this? Yes. Based on this, we develop our own system in-house. We build an in-house system that is a camera integration system that will verify the processes, that will verify the real-time verification of the medication that prepared inside the hood, as well as the control from the prescribing till the administration of the medications. So by applying multiple strategies in our system, we came across one of the study, reduction in the medication error associated with the chemotherapies. So initially we identify the whole process, and then there is the intervention phase. So after applying multiple strategies into our system, and you see after the post intervention phase, we decrease the overall trend of that. So this is one of the learning thing that if you apply a controls processes while reviewing international standard or the guidelines, you can develop own processes, own guidelines, and own activities on that. So as said earlier, our healthcare system is quite weak. If we pull out anything, it will drop out. Anything you add will add the value in that. The most important thing is, so you have the integrated system, development of the guidelines based on the international standard. सबसे पहले उर्दू में बात करने इसलिए जरूरी है कि समझ आ जाए, हमें सबसे पहले अपना कानून ठीक करना है, अपने स्टूडेंट को उस लेवल पे लेकर आना है ताकि वो किसी लेवल पे जा सके और उसको एड्रेस कर सकें. An expert of the relevant field into the relevant department. That is very important. And for the student, आप पढ़ते हैं, सारा कुछ हासिल करते हैं, लेकिन एक चैप्टर ऐसा छोड़ देते हैं और वो चैप्टर आपकी प्रैक्टिकल लाइफ में अप्लाई होता है और उस टाइम आपके सामने एक मरीज होता है और आपने वो चैप्टर छोड़ा होता है जिसमें उस बंदे के लिए इलाज के लिए सब कुछ लिखा हुआ था. So that is very important in that. And the healthcare system should be integrated. Like in the Pakistan, we have the different provinces and whole processes activity is carried out that in the Punjab, we have the green board, but in the KPK, we have the red board for the pharmacies. So it should be integrated into the whole system. That will help the whole processes as well. These are the references and thank you everyone. Thank you.
Thank you. Thank you, Mr. Shamaz. Now we will begin with the question and answer segment.
We will culminate with an interactive session of question and answers. At the end of this symposium, we would like to invite you to participate in an interactive segment that allow an engaging exchange of ideas and insights.
Please keep remember to answer your questions. The questions that would be asked should be concise and should be related to the symposium's theme. And for the session, I would like to call upon stage Sir Mujtaba.
So our first question is online. I believe only chair can answer. So the question is, to work on the ecosystem, how health institutes and pharma industries work together to ensure patient safety.
So-
Yes.
Would you please repeat the question?
Yeah. So to work on the ecosystem, how health institutes and pharma industries work together to ensure patient safety.
On ecosystem.
Yes.
What mean ecosystem? Who raised the question?
It's from the online participant.
So what is ecosystem? Any idea? So this is all environment basically. So I mean, just first we have to understand what is ecosystem.
Right.
So how the ecosystem actually integrated with the healthcare provider?
So how basically what I understand from this question, that how hospitals and pharma industry can work together to ensure patient safety.
Oh, okay. So, well, health industry, if you have to look at over the span, farm industry versus practicing or service-oriented industry. Well, look at first start where the process start. It start from the manufacturing, selection of the drug, selection of the raw material. So as a pharma industry, how actually you are preparing a quality drug is the most important part. This is the first element which ensures the patient safety. So for example, if the pharma industry is not manufacturing good quality products, it may jeopardize or may risk the safety of the patient. This is the first step of the pharma industry. And now the second step, once it's done, then the second step is how it's transported and how it's in the hand of the healthcare provider. So once you have the drug in the hospital or at the site, what is your role as a pharmacist to ensure how effectively and safely you use the drug over the patient? The basic purpose, where we are actually all together here is how to improve the quality of life of patient and how can we reduce the toxicity of the drugs to the patient. So as a pharmacist, your role is what? How to improve and how to decrease the toxicity of the drugs. Now, your question is basically how is integrated between these two drugs. So I have seen there are so many examples here, and we have experienced as well, how we are actually dealing with the pharma industry and how we are putting effort and collaborating with the pharma industry. We have so many examples like we help the interns to come here and to work with us, number one. We also sometimes give a feedback to the pharma industry, how they can improve. So for example, I think in the recent literature, we have studies that some of the formulation require, for example, IV anti-tuberculosis drug. Now, there is a need. How can we improve this? How can we coordinate with the pharma industry to formulate this drug? I think Dr. Fakhr have discussed a nanoparticle. This is one of the major area where we can improve the patient safety. How can the pharma industry help us to improve the targeted therapy? How the pharma industry can improve to reduce the toxicity of the drug. So they are all things which help to integrate in between the pharma and the health industry. They collaborate each other and work together and then foster a research so that they can improve quality of patient life as a team. And this will definitely improve the quality of life. If you want to add something.
I will add another point. As far as our pharmacovigilance system is concerned, so that is a multidisciplinary system, pharmacovigilance system. Although we don't have that system in true sense, its implementation is concerned. In pharmacovigilance, the pharmaceutical industry, hospitals, healthcare professionals, physicians, pharmacists, nurses, and even the general public, they have the responsibility. If you look at the FDA pharmacovigilance reports, so you will find reports from manufacturers, from healthcare professionals, and even from general public. So this is a collaborative work. Another example, if you remember the incidents that took place at PIC, Punjab Institute of Cardiology, isotape. So that was purely a manufacturing issue that occur at the level of manufacturing unit, and so many deaths that occur. So the issues that is multifactorial, and there is need of a collaborative approach in order to improve the safety. Okay.
Thank you, chairs. Any question from the audience? So if you have any question, please come to the mic.
I want to ask the role of nanotechnology or nanomedicine, especially to the oncology drug resistance in the against the anti-cancer drugs. So can nanotechnology or nanomedicine can help in reducing the drug resistance developed against the anti-cancer drugs? And I have one more question as well about the drug availability and drug shortage. Drug shortage is something else, and drug availability of new, especially new anti-cancer drugs. Because for the last couple of days, I was listening to a lecture, and people are talking about immunotherapy and some other drugs that we are not using in Pakistan. So as per I'm concerned that we are suffering from drug shortages. And what about we are doing about the availability of new drugs, for especially to the oncology drugs, like trastuzumab and pastuzumab? There are many drugs that we don't have, but currently they are in the practice and people are using them. And our patients are still on the old drugs that were used like a decade ago for those cancers. So what are we doing about the availability of those new drugs? Thank you.
So Dr. Fakhr is here. Otherwise, I will try to answer this.
So I believe he left. So
If Dr. Fakhr and okay, the second question goes to Wahab. Would you please
yes.
Share some your knowledge?
Sorry, shortages के बारे में आपने जो दोबारा repeat कर लें.
So the Wahab sahab, the question I would rephrase the question. The question was, so there are novel and newer anti-cancers. They are being introduced into the market, and some of them or most of them, they are not available here locally. So how we can improve this?
Yeah, उसमें से different जो आप बता रहे हैं, जिस तरह आपने example दी different trastuzumab और pertuzumab और different drugs, तो there is some regulatory issues जो कि DRAP ने अब तक approve नहीं की, लेकिन इसमें mostly जो drugs हैं, जिस तरह आपने example दी trastuzumab, which are using by different consultant, वो एक अलग issue है कि हमारे मुल्क में unfortunately they are very costly. और पेशेंट उसको नहीं अफोर्ड कर सकते. जिस तरह वी आर यूजिंग दिस बोथ ड्रग्स एंड अदर डिफरेंट मोनोक्लोनल एंटीबॉडीज इन आवर शौकत खानम, बट बिसाइड दैट डिफरेंट कंसल्टेंट आउटसाइड दे आर नॉट यूजिंग इन देयर थेरेपी ड्यू टू हाई कॉस्ट, कि पेशेंट अफोर्ड नहीं कर सकता. सो फॉर दैट रीजन डॉक्टर्स फिर ओल्ड थेरेपी पे चले जाते हैं. तो दैट्स द रीजन. बाकी तो ये सारी ड्रग्स जो आपने बताई हैं, तो ये हम यहाँ पे शौकत खाने में भी यूज हो रही हैं, और कुछ स्टिल इन द ड्रैप पाइपलाइन में है फॉर द रजिस्ट्रेशन. तो मोस्टली रजिस्ट्रेशन की इश्यूज हैं. और आजकल जो एक और इशू जो आप एस यू नो के फ्लक्चुएशन ऑफ द डॉलर प्राइसेस, तो इवन पेशेंट भी नहीं अफोर्ड कर सकता. और दूसरा जो ड्रैप या वो है जो सप्लायर है या जो यहाँ पे सप्लाई कर रहा है, उसको ड्रैप वो प्रॉफिट रेट नहीं दे रही. जिस तरह मैंने अपने उसमें कहा कि ड्रैप को चाहिए कुछ इंसेंटिव्स दें टू द सप्लायर्स, या उनको वो टैक्स फ्री करें कि जहां पे उनको कुछ प्रॉफिट मिल जाए. जब उनको प्रॉफिट नहीं होगा तो वो क्यों लाएंगे पाकिस्तान? तो देयर नीड्स सम रेगुलेशन फ्रॉम द ड्रैप कि वो इस तरह की चीजें वो करें ताकि जो डिफरेंट सप्लायर इन ड्रग को पाकिस्तान में इंपोर्ट करें.
So I have one comment over. Thank you, Wahab.
Thank you.
So there are certain reasons. One of the reasons I think Wahab has already been described. Most of the novel drugs, mainly the monoclonal antibodies, or if you have to look at the targeted therapy, they are actually patent drugs. So for example, if somebody in USA or USA discovered and invented a new molecule, they actually patent this drug. For example, trastuzumab, once is discovered in USA, the patent or patency of this drug was 15 years. So none of anybody can, manufacture even their biosimilar itself. But few of the countries, they can manufacture and they develop as well. I remember one of the country, India, they have developed biosimilar. Even the patency wasn't expired. So this is one of the reasons the availability of these drugs are a little bit challenging. Second is the cost. These are high cost medicine. Third is how the pharma is interested to introduce and get registered within our country. This is another one segment. So most of the pharma industry, actually, their perspective is to look at the business. Can we earn profit from that drug or not? So their perspective is a little bit different in comparison to the patient safety. So this is another one reason of non-availability of certain essential products. So I think some of the regulatory relaxation is required. And for patent drug, obviously, we don't have any other option until their patent has expired. But how can we attract these pharma companies to come here and introduce their technology within our country? So regulatory can do something. So we will push regulators to change their regulation and rules and bring all these companies, but with the technology, not as an import product. So once you have the technology, so this will bring up the expertise here, as well as this will improve the, professional, the uplift of the industry, of the farm industry here in Pakistan. I hope the answer I've done. Thank you.
Thank you. Dr. Inam, yes, please, can you hand over the mic?
Okay, I want to just add something to it, that the lack of legislation or a policy for the national medicines or the medicine-related activities in Pakistan is the major hurdle in importing or regularizing or making the availability of such drugs in the market. Being a part of the national medicine policy draft, it was basically initiated in 2019, but unfortunately the COVID pandemic has stopped the draft of the national medicine policy then and there. Afterward, it has been reinitiated in 2023. A draft has been prepared, which is put to the cabinet for certain changes into the law department at the federal level, in which facilitated registration and incentivized registration has been included for all these drugs which are short, and particularly for the orphan drugs. Additionally, a part regarding the technology import and the development of the technology, inland technology in Pakistan, which could be able to develop or manufacture their drugs. So as soon as possible, the national medicine policy is approved by the government. Hopefully, the facilities or the rules therein would facilitate the importers or the pharmaceutical manufacturer to manufacture or import drugs which are oftenly short in the health sector. Secondly, I would add to the earlier question that how can we improve the medication errors or the environmental hazards which are associated with the drugs or with the medications. For that purpose, also in policy board of the DRAP, there are activities which are underway that they are improving the CGMPs level at the manufacturing, but we are lacking the rules or regulation, particularly in the hospital sector. We have just limited definition or limited work in the DRAP Act, and we have not made so far any rules or any bylaws or any regulation which could govern the pharmacy, the hospital sector, or the compounding or the administration of the drugs at the hospital level. So that is also underway, and hopefully in the next year or by the next, as soon as a government come and they have the authority to approve those rules or acts from the cabinet, hopefully that could be implemented then.
That's great. Thank you.
Thank you.
Excellent.
Any other?
So we have hardly few minutes left, 1 or 2 minutes, then we will close the session.
So I have a question from Mr. Jahanzib sir. So my question is that how to apply sterile area requirement at the legal level of the government? What is the way forward on that? So how we apply a legal thing that sterile area is the minimum requirement to prepare the medication at the government level, or that, and when we apply this, that apply to the whole country as well. So what is the way forward on that? How we move forward on this?
Okay, ji. The thing is, actually, we need to incorporate these as as an accreditation standards for the healthcare institutes. Every healthcare institutes who opts for license or registration at the government level, they must provide a standard, or you can just simply reflect the USP 797 requirements in the legislation, and then they have to follow these standards and rules before opting for the license as a hospital for oncology services.
Yeah.
Thank you. Jahanzib, actually, I think if you have to look at their presentation, he is one of the major person who highlighted this issue. And you are asking again the same question, but well, fine. This is a dire need. And I think if you have to look at what's happening currently in all over Pakistan, when you reconstitute or remix the anti-cancer drug, specifically I'm talking about the anti-cancer drug, it is highly mutagenic, carcinogenic, teratogenic. And if you have to look at, Shamas has shown some closed transfer device. What is the purpose of closed transfer device? Once you withdraw the drug from the ampule, there is a fume actually originated during the withdrawing of the ampule. Because if you are a pharmacy and you have some idea about this, they have some pressure within the vial. Once you inject some volume, either in the water for injection or some liquid, they actually generated a fumes or some smoke, which is highly dangerous for the personnel who is involved and reconstituting this injection. And I feel most of the nurses who are working at the ward and they are mixing and reconstituting all these drugs, they are on high risk, at place. So I think there's a dire need to start and implement the clean room or aseptic services. In our hospital, none of any nurse or any doctor can reconstitute any drug out of the pharmacy. Pharmacy will dispense, reconstitute, remix, and then he will dispense out to the patient area. So I hope the answer is done.
Thank you.
So this is a last question because we are now yeah.
My name is Arija Beg, pharmacist, emergency department, Lady Reading Hospital, and I'm a PhD scholar in University of Swabi. Sir, my question to you is, what are the Shaukat Khanum mechanics, SOP, for the safe disposal of the clinical waste related to the oncology? As you have mentioned that these waste can even go for the contamination of the staff, and as some of the participants, they have shown the slides in which the nursing staff and the pharmacists, they suffer from the eventuality by dealing with the anti-cancer drugs. So what are the safety protocols you are basically following? And what is the safe disposal SOP do you have? And what is the feature of your building facility for the safe disposal of these clinical waste? Thank you.
Your question is safe disposal of these hazardous drugs. Fine. Okay. So as per standard, all cytotoxic drugs, these are actually by default infectious as well as obviously carcinogenic, mutagenic as well. So the standard is saying all cytotoxic drug, their waste or their remnants or unused or used or remainings must be incinerated, and must be incinerated at approximately 1100 degrees Celsius temperature. Okay. So we have a very stringent protocol at ASCIM Lahore. What we are doing, so we have a different segregation of the waste, number one. So household waste will go to the white bag. We have three types of bag. White bag is a household bag. We have a yellow bag. All infectious waste will go to the yellow bag. And then we have a red bag. Red bag is specifically for cytotoxic drug waste. So all healthcare staff, either in pharmacy or in the wards or at chemo bay, where chemo actually is going to be administered, they all must be discard all used, unused chemo bags whatsoever within the red bag. Now, this red bag is collected by the specific staff, porter, and then bring to the storage area. From there, we have an incinerator at ASCIM Peshawar, and all such cytotoxic drug incinerated within the facility. At Lahore, we have a contract services with one of the incinerating company, and they actually pick up all red bags and they incinerated there as well. And this facility as well as Peshawar and Lahore, both are EPI, as the Environmental Protection Agency approved incinerator facility. So this is the way how to dispose all these drugs. So I would like to, thank you, all of you. Specifically, I would like to thank all worthy speaker. They spent giving us time, and specifically all the participant, the audience, mashallah, an excellent participant and audience. One announcement I would like to give you. We have another one session is most probably has been started for Hassan Rashid Memorial Research session. It is going to be start at Kehkashan Hall. So I would like to urge to please go there and attend the session. This is purely a research-based session, and I hope you will get some idea and some knowledge from that session as well. So thank you very much to all of you. Allah Hafiz.
Thank you very much, everyone.
जी, so Kehkashan Hall hai. Please, if you can just move towards Kehkashan Hall.